Hi, this podcast is on shock and multi-system failure. This is Mrs. Hauk. The definition of shock. Shock is a condition in which tissue perfusion is inadequate to deliver oxygen and nutrients to support vital organs and cellular function. So this goes along with our concept of perfusion for N250. And this is down to the cellular level of not getting enough oxygen and nutrients from lack of tissue perfusion. Without treatment, this is what happens. You continue to get poor delivery of oxygen and nutrients to the cells, and the cells then start to starve. They start to starve so much that they die, and once the cells start to die, this causes organ dysfunction, which leads to organ failure and eventually death. This is a general overview of shock. We will get into specific types of shock in the next PowerPoint. But shock can be very life-threatening. It has a variety of causes, and it affects all body systems. Even hypovolemic shock or cardiogenic shock, that's just classifying it by the cause, but any kind of shock will affect all body systems. It can develop rapidly or slowly, and once again, that depends on what causes the shock state. Its progression can be unpredictable. Some people can respond very well to shock, some people won't. Sometimes it has to do with their underlying comorbidities, but not always. Shock, like I said, is categorized according to the underlying pathophysiologic process, i.e. hypovolemic, cardiogenic. And in treating shock, one must be able to recognize subtle signs, not just the obvious signs, because usually once you see the obvious signs, we start having organ dysfunction. So being able to recognize subtle signs can prevent any organ involvement. What is required for adequate tissue perfusion is an adequate pump, an effective vasculature and circulatory system. So what do I mean by effective vasculature and circulatory system? Think about that. And you need to have sufficient blood volume. So all three of these things need to be in place to have adequate tissue perfusion. So if only one of the three is impaired, tissue perfusion is threatened or compromised. The body will use a variety of compensatory mechanisms to try to restore blood flow and make sure that tissue perfusion is adequate. Think about what compensatory mechanisms the body does for inadequate tissue perfusion. Tachycardia is one. Vasoconstriction is another. See if you can think of any others. The pathophysiology. In all types of shock, the cells are starved of oxygen and nutrients. So instead of having aerobic metabolism, they revert to anaerobic metabolism, meaning metabolizing without oxygen. This creates an acidotic intracellular environment, which is not a good environment at all. We have substances released in the system that further aggravates the situation. We have catecholamines, cortisol, glucagon, cytokinins, and they result in hyperglycemia and insulin resistance. So it's hard to mobilize glucose into the cells for metabolism. So there's a nutrient the cell is starved with. And think about it, catecholamines are released. This is going to help vasoconstrict and increase your heart rate. Cortisol is the steroid. That's going to increase your blood sugar, lead to that hyperglycemia. Cytokinins are part of that inflammatory mechanism. So it's not a good situation. Anaerobic metabolism causes lactic acid levels to rise. So that's one way we can determine whether our patient is going into shock, is follow the lactic acid levels. Also, the releasing of the cytokinins, that inflammatory process, increases capillary permeability. What happens when you increase capillary permeability? You have fluid shifting. Like I said, tissue perfusion requires 3 of those things: pump, effective vasculature, and sufficient blood volume to be adequate. But it's the result also of cardiac output and systemic vascular resistance working together. Your cardiac output is the amount of blood pumped by the heart in meters per minute, and systemic vascular resistance is the resistance to the flow of blood out of the left ventricle. So how hard does the left ventricle have to push to get that blood out? How vasoconstricted or vasodilated is your systemic vasculature? These 2 factors, and being able to keep them adequate, will help determine the extent of the course and the prognosis of the shock. We have 3 stages of shock. We have pre-shock, shock, and end organ dysfunction. Pre-shock is a compensated. This is when the body mechanisms will compensate for the beginnings of shock. Shock is when the body can no longer compensate, and without intervention, the patient will die. And organ dysfunction means that the organ damage that has happened is irreversible at this point. So in pre-shock, the blood pressure often remains normal and helps maintain adequate cardiac output and systemic vascular resistance. And by normal, it doesn't have to be 120. It could be 95, okay? We're talking anything above 90 is considered normal in this situation. And because their blood pressure is running on the lower side, it's still considered normal. How do we get this? Through vasoconstriction and increased heart rate that I've been talking about, also increased contractility of that left ventricle. The body initiates the fight or flight response, releases catecholamines, blood is shunted to the central organs, meaning the periphery vasoconstricts, shunts that blood. So what are you going to see in your extremities once that happens in the pre-shock phase? In the pre-shock phase, your extremities could be cool with a delayed capillary refill because of the compensatory mechanism. Early intervention in these stages can actually help prevent the progression to shock or the non-compensatory phase. How do we manage the pre-shock phase? Well, identifying the cause and trying to correct that underlying disorder that caused it. Was it hypovolemic, cardiogenic? Was it distributive? Initiating measures aimed at supporting the body's compensatory mechanisms. We want to support cardiac output. We want to support our systemic vascular resistance. So what does that mean? Fluid and medication therapy. Constant monitoring of our hemodynamic status, which includes not just pulse and blood pressure, but our temperature, respiration, oxygen saturations, but other things that determine perfusion, level of consciousness, urinary output, skin temperature and color. We're looking at our lab values. Remember that lactic acid level. Once the body loses the ability to compensate, we go into the shock phase. This is when our signs become obvious, and organ dysfunction is already started. Heart and kidneys are usually the first to show signs of dysfunction. The inflammatory response is activated full-blown here in this phase, causing more capillary permeability and impairing coagulation. We have decreased perfusion leading to an acidotic state. When patients are in a metabolically acidotic state, medications that we use to treat certain things don't work as well. Diuretics don't work as well. Our vasoactive drugs don't work as well. So in this phase now, we need aggressive treatment. It's essential for the patient to survive. Doesn't mean they won't survive without some organ dysfunction, because they may end up with residual organ dysfunction, like renal insufficiency. But for them to survive, you need that aggressive treatment. The kidneys, unfortunately, that's why we look at urine output, really are our indicator of where the organ involvement is. So how do we manage our patient in the shock phase? The patient needs to be in ICU. They need continuous hemodynamic monitoring. They need monitoring of their ECG. We need to look at ABGs, look at their acid-base balance and work on correcting that. Look at their electrolytes. We need to do strict I&O, and we need to constantly monitor these patients for physical and mental status changes. We are going to give a rapid administration of fluids and medications, all the while having invasive lines to monitor their effects, such as a central line, an arterial line. They may require supportive therapies at this point. They may need to be mechanically ventilated. They may need to be on dialysis, whether it's hemodialysis or continued renal replacement therapy. They may need something like an intra-aortic balloon pump to assist cardiac function. And the nurses caring for these patients need to have an expertise in assessing and understanding the significance of changes in data. Our overall treatment of shock depends on what type of shock it is and its underlying cause. So some of the goals that we're going to try to achieve is optimizing intravascular volume. If they're third spacing because of that increased capillary permeability, we need to try to pull that volume out of the tissues into the vasculature. If they're low because of hypovolemia, we need to give fluids. For that, supporting the pumping action, do we need to give medications? Do we need a device inserted to help with the pumping action? Improving the competence of the vascular system. What do I mean by that? Well, are we too vasoconstricted or too vasodilated? And do we need to give medicines to reverse either or? Supporting the respiratory system could mean something as simple as giving the patient oxygen, or as much as mechanical ventilation and actually taking over the respiratory effort for the patient. They need continual assessment and reassessment of the body's response to interventions. Are our interventions working, or aren't they working? And at this point, we need to involve patient and family in the plan of care, especially when we start to see organ dysfunction and sense an end of life. We are the ones that initiate this in the families. Tell them, be honest with them. Treatment is not going as we expect it to. You need to speak with the physician. You need to know what your family member would want in this case. End organ damage, when it becomes irreversible, we cannot restore tissue perfusion. And organ damage can become so severe that the patient cannot survive. We do not want to get to this point. If we think that we're headed to this point, that's when we need to speak to the family and ask them what their family member would want, encourage them to speak with the physicians. And we don't like to take away hope from families, but we also need to be very honest. And then I put the formula there for mean arterial pressure, or MAP. If you remember what that is, it's 2 times your diastolic plus your systolic divided by 3. And when we're looking at shock, to get adequate tissue perfusion, our MAPs need to be greater than 60. So we may titrate medications greater than a MAP of 60. Sometimes the physicians even like a MAP of 65. It's definitely physician preference. So this is the end of this podcast, but not the PowerPoint. The next podcast will finish this PowerPoint. Thank you.